At today's Johns Hopkins Health Policy Forum, Johns Hopkins Medicine welcomes Donna Shalala. Described by the Washington Post as one of the most successful government managers of modern times, Donna Shalala has more than 40 years of experience in government and education administration. A distinguished scholar and educator, she served as president of Hunter College, as chancellor of University of Wisconsin-Madison, and as president of the University of Miami. And she's currently trustee professor of political science and health policy at the University of Miami. A proven leader, Dr. Shalala holds the record as the longest-serving Secretary of Health and Human Services, a role she had for 8 years during the Clinton administration. In 2008, President George W. Bush selected her as the Presidential Medal of Freedom recipient. In 2010, she received the Mandela Award for Health and Human Rights. And from 2019 to 2021, she served as the U.S. Representative for Florida's 27th Congressional District. Now we'll join our host, Johns Hopkins Health System President and Johns Hopkins Medicine Executive Vice President Kevin Sowers, as he welcomes Dr. Donna Shalala to the forum.
On behalf of the Hopkins community, it is our honor and privilege to have Dr. Donna Shalala with us today's Health Policy Forum. Dr. Shalala, thank you so much for joining us.
Hey, you're welcome, Mr. President.
Well, you can call me Kevin. Listen, we really appreciate, and I especially appreciate this incredible honor to meet you, because you are an incredible role model as a leader. And I just want you to know how much we appreciate your presence here with us today. Well, you know, I know we have something in common, and we were talking a few minutes. I'm told that you grew up in Ohio and in Cleveland. And I understand that a lot of your family still is there. So let's talk about your formative years. What influenced you to pursue a life of service?
You know, it was chancy. It wasn't as conscious as many people think. When I was a senior in college, I always wanted to be a journalist. And I had worked at the Cleveland Press, as a matter of fact, during the summers when I was in college and in high school. And so I wrote to the New York Times and the Washington Post. They didn't have any jobs, but I remember laying out on my bed. I just hedged my bets. I applied to medical school, to law school, to the graduate programs in political science. I had spent a semester in Washington, to the Peace Corps, because I had been inspired by John Kennedy, and many of my friends were applying to the Peace Corps. I laid all my acceptances out on my bed. And I asked one question: what would be the greatest adventure? And so it was clearly the Peace Corps. So I joined the Peace Corps. And, you know, after that, 2 years in the Peace Corps, and we could talk a little about that. I spent a year going around the world. I think my family thought I was a flake, a little bit of a flower child. I was never going to come back. But I followed my boyfriend to graduate school at Syracuse. I still wanted to be a journalist. And he hated graduate school. I loved it. I stayed and got a PhD, wrote again to the Washington Post and the New York Times. They didn't have jobs. So my major professor said, well, you might as well be an academic, and arranged for me to go to New York. And I eventually ended up at Columbia, got my tenure there in political science. And educational policy studies. And, you know, that was that. And the rest was, you know, opportunities to go into government, to study government. And I've been in and out of government ever since, but it wasn't as conscious. Most young people think careers go straight up. It was kind of zigzag, who was there at the time, opportunities. So that's the answer to the question.
Well, you know, I know you also received your bachelor's degree from Western College for Women in Ohio, where you studied history. And then you went on to earn a doctorate degree from the Maxwell School of Citizenship and Public Affairs at Syracuse. Now, you spoke to the fact that you joined the Peace Corps, and I think what you left out is you were one of the first Peace Corps volunteers from the United States. Tell us a little bit about that experience, and specifically what lessons you may have carried with you into other facets of your life and career.
You know, I was one of the first Peace Corps volunteers, thank God, because they were not a bureaucracy and they weren't very well organized at the time. I served in Iran. I went to the Middle East. My family is Lebanese. I wanted to go to the Middle East, and I think I had a choice between Turkey, Morocco, or Iran. And even though the major language was not Arabic, which I knew a little of, I chose Iran because of its fascinating culture and history. I served in a mud village where we built an agricultural college way down in the south. I learned a lot. First of all, I learned how to be fearless. Second, I really learned about poverty. As much as I had studied poverty, listen, I come from a working class family in Cleveland. As much as I had studied about poverty and understood the race issues in the United States, you live with some of the poorest people on earth, and you really begin to understand poverty, a new culture, different cultures. We lived in the Arab area of Iran, so the languages switched from Persian to Arabic and back. We made great friendships there, but I learned self-reliance. I got a kind of self-confidence that wasn't an arrogance, and frankly, I became a citizen of the world.
Let's talk about that for a minute, because you have spent a lot of your career in public service. You hold the record as the longest serving Secretary of Health and Human Services in the US history, and you have managed entities with thousands of employees within a massive multi-billion bureaucracy. As was noted in the opening video, the Washington Post named you one of the most successful government managers of modern times, and that's quite an accomplishment. What's your secret, and any sage advice for our listeners also leading large, complex organizations?
I was ready for the HHS job in terms of my ability to conceptualize it, because I had been leading a major research university, the University of Wisconsin. Kevin, if you think about your job, HHS is not much different in terms of managing strong personalities. You have to manage the chairman of surgery and the other chairman. At Wisconsin, I had to manage very powerful deans. And when I went to HHS, I looked at FDA, NIH, CDC, the Public Health Service, the Agency for Children and Families, which had leaders I had appointed. They had strong egos, they knew their jobs, but they needed to be managed as a team. So I had an ability, because I had been in research universities, to conceptualize the management of strong personalities and to learn how to weave them together with both the policy-making process as well as the budget process. And teams are very important in leading complex institutions. I also had great respect for the civil service. I had earlier in my career been an assistant secretary at HUD and had learned the importance of the inspector general and that relationship. And so I also learned at HUD that I had to jump the gun in building a team. So I went to Bill Clinton and Al Gore with my list of people I wanted for the top jobs long before they ever had a White House personnel office. So I was probably the last secretary of HHS that got to build their own team, and then got to keep them for 8 years, which no one has ever been able to do. So it was a combination of my ability to conceptualize, to understand multiple cultures. In a university, there's a big difference between the culture of the law school and the culture of the medical school, and the culture of arts and sciences. That's also true in a place like HHS. NIH is very different than FDA or than CDC in terms of their cultures. They may have the same kind of degrees, but they have different cultures and different responsibilities. So, and I had Social Security as well, which is a totally different culture. So that's it. My skill set is my ability to understand multiple cultures and to understand how to wield people together using both the policy development process as well as the budget process.
It really is about shaping teams' way of thinking and advancing the order of the organization. And just so you know, I'm very lucky to have an incredibly talented chair of surgery here. So
Yeah.
it's very committed to the mission, and actually have an entire group of clinical chairs here that are are incredibly, I'm very blessed to be able to work with them. They really care about the mission, all parts of our mission here at Hopkins.
But they also have different challenges.
Yes, they do, based upon their specialty.
Yes, and understanding that is also part of this.
Yep. You know what, you and I were talking a few minutes ago, when you were HHS secretary, there's all kinds of public health crises that comes at you. And you were in a very difficult position because you actually were a part of the AIDS epidemic. And other healthcare crises has come along, like COVID. We were talking about the issue of opioid deaths, the ongoing mental health crisis that's worsened post-COVID. Talk to us a little bit how you'd advise health policy leaders to prioritize given all the competing demands we have from a healthcare perspective today.
Well, you have to do two things. Number one, you have to look at the big crises and make sure you have a team that's managing that. I had the great honor of working with Tony Fauci on the AIDS crisis. And at the beginning, everybody was dying. By the time we left, we had treatments for people around the world, and only enhanced by the work on PEPFAR that George Bush, President Bush did afterwards. So, and we had people in our face. We could not make a speech anyplace without AIDS activists being all over us. Basically screaming for help. And we understood that. And so Tony was war weary by the end of that crisis, but he went on to others, as all of us did. And we had great challenges. We started out with a Democratic majority, and within 2 years, we were doing everything bipartisan. And to get anything done, we had to do bipartisan, lots of bipartisan things. We only had half the kids in the country immunized by the time they were 3. That was a huge challenge that we took on, and we got them basically 90% of them immunized. But staying focused, identifying those issues, and being open to new ideas. I'm a juggler. So I can stay focused on the big issues that are going to affect millions of lives in this country and around the world, but at the same time, making sure I'm listening very carefully to the stakeholders, but also to the youngest researchers in my organization. So we had to do things like, we had the opportunity to double the NIH budget, which made a huge difference, frankly, in COVID, and built some of the great research organizations in the world and sustained them and trained a new generation of people. I'm very proud of that. I'm proud of getting immunizations done. I'm proud of getting my arms around AIDS, but there were also smaller things. When I first arrived, I sent a note out to the department, said, anyone that's got a good idea that we ought to be running with right away, let me know. And some researchers came in from NIH and they said they had this finding. The finding was, if you put a baby on their back, you could reduce SIDS, sudden infant death syndrome. And I said, so what's the reason for that? We don't know what the reason, but we do know if you put the kid on their back. So we ran a campaign called Back to Sleep. Every hospital in the country, when the baby was born, told the parents to put the kids on their back. We got the diaper companies to put this side up on it, but we had a big challenge with the grandmothers. So we ran a campaign with AARP because the mother would come home and the grandmother say, those doctors don't know what they're talking about, and flip the kid over again. So, but the Back to Sleep campaign was hugely successful. We have reduced SIDS in this country by at least 70%. But it was a small piece of research so that would affect heartbreak.
You know, I think you and I were talking a few minutes ago, when you talk about public health, you can't talk about public health without talking about nursing. And I know you played an incredible role at the Institute of Medicine report on the future of nursing, and just wanted to hear some of your thoughts as we have gone through this, the last 2.5 years of the pandemic and the impact on all of our workforce, but especially on nursing, and just hear your thoughts of the role of nursing in the future.
Well, I think of nursing as central to the healthcare system. That the way nurses are trained is to be patient-centered. That's very important, whether you're in COVID or not in COVID. And the respect nurses need to have. We wrote a report that said, "Hey, states, if you're insisting that people get trained up to this level, then you ought to give them the authority up to this level. They ought to be able to practice up to their training." And that's important for the entire healthcare system. We'll never have enough of family doctors, primary care providers, but we have advanced practice nurses, and they can make a difference. And we've got to expand their scope of practice, as we have during COVID. There are 26 states that have already expanded their scope of practice. But I see nurses as part of a team. Sometimes they're leading great health organizations, as you have at Johns Hopkins, but as part of a team, they can produce better outcomes. And they are not handmaidens to medicine. They are part of the team and a critical part of the team, and need to be treated like peers. And that's what our report essentially did. It has made a difference around the country. The role of nursing has changed, particularly for advanced practice nurses. We have a long way to go. But everybody, the country respects them, respects their role as caregivers. It's also true of physicians' assistants and of the other people that work in healthcare. And I think during COVID, we realized that it wasn't just the doctors, who I love, but it's also the nurses and the technicians and the physicians' assistants and the whole team that saves lives.
It really is an incredible team sport, and it takes each and every one of us to be successful. You know, Dr. Shalala, I think you'd agree with me that we live in a very complex society today, more complex than I remember in my life thus far. You've got the political discord, you've got the social unrest, the public trust in the CDC and federal officials have taken a beating over the last period of time. Do you see the same regarding our global leadership on health, and how do we actually rebuild that trust?
You know, it's going to take a lot of leadership. I had a rule at HHS. It was called the Shalala rule, that whenever the healthcare leaders, basically the people with MDs, got in front of a camera, they had to have their white coats on. I said this to Gail Walensky the other day, the head of CDC. I said, "You guys look like a bunch of politicians in your little squares. You got to put your white coats on." And I never let anyone have a press conference at the White House. So there are things we can do to regain trust. Some of them are cosmetic, and some of them are simply a repetition of educating people about how science is going to change. We should have told people from the beginning, this is what we know about COVID, but it's going to change. And we're going to be very transparent with you as we get more information. So masks on, masks off, being honest with the American people would have helped. I think we've learned a lot of lessons about this, about communication, but there's always been an anti-vax stream. There's always been an anti-science stream in American politics. There's no question about it. It's just that we've had leaders that have overcome that, and particularly on the Republican side, who have overcome. The NIH budget has always been bipartisan. It continues to be bipartisan because both parties realize that it saves lives. But we need to rebuild public trust about the institutions in our society. And the way to do that, I think, is to rethink our communications and our honesty with the American people, and to do it step by step.
You know, it's interesting that you say that, because as I reflect upon your comments, at least in my life, I don't remember a time where I've seen masks and the science really take on a political side that really was more about politics than it was about challenging the science, and it's still a very interesting time in our country as I think about that. You know, during this time, it also challenged us to think differently. And we had to move to telehealth to be able to continue to provide healthcare in an effective way. I don't think we'll ever go back now. So some good things came out of the pandemic, but just wanted to hear your thoughts on the role of telehealth in healthcare moving forward.
You know, we've been fooling around with telehealth for a long time. We have struggled with how to reimburse it, what role it should play. COVID brought it to the forefront. And in many ways, we're in the golden age of telehealth. We have to use it very carefully. What impressed me was how much the specialists like it. I had seen primary care doctors use it for rural areas and people use it for handicapped kids because their parents couldn't get there, but I had never seen the neurologists and the oncologists and all of those use telehealth as effectively as they're now using it. And the fact that the specialists have adopted it, I think will make a big difference. I think it's in the future. I think it will help us get people into compliance. We still have pretty large numbers of people that don't show up for their appointments, but they show up for their telehealth appointment. Now, we have to also remember that there are a lot of seniors that can't use telehealth, but they can use the telephone. So we still have to continue to use the telephone until we change generations. Once we change generations, then everybody will be on their laptops or their iPads or whatever, or their phones to talk to their nurse or to their doctors or whoever their healthcare provider is. But we will get better compliance. There's no question about it. We have to still work on the reimbursement piece, but we can solve that problem.
I think you're right. I think there will be a next generation that will force healthcare more towards telehealth because that's what they grew up with. So I think we have to prepare ourselves for that. You know, there were other lessons that we learned through the pandemic about the disproportionate impact of COVID on vulnerable communities. And you and I were talking about that just a minute ago. They were hit by illness, job losses, and also what we saw here in our own community was food insecurity. As a health system, we are doing our part, and I'm proud we recently secured a multi-million-dollar grant and partnered with local vendors to provide food to local families in hard-to-reach communities.
Mm-hmm.
During the pandemic, we temporarily opened food pantries for our staff at some of our hospitals. But we know this is a problem many communities are experiencing across this country, which leads to the question, as hospitals and health systems invest greater attention and resources into addressing food insecurity and other social determinants of health, are there innovative or inspiring models that you've seen across the country that really stand out for you?
You know, everybody's tried everything that you've suggested, including giving kids backpacks on Friday with fresh fruits and vegetables to take home. Food insecurity is related to income, but it's also related to areas of the country that don't have good opportunities to get fresh foods. So it's got to be a multifaceted approach. We can't expect hospitals to do it all. Hospitals have to join with the school system, with the food stamp programs, with the Meals on Wheels, with all of the programs, and make sure no one falls between the cracks. And part of this is just strategizing in the community and then making sure that someone is on top of every element so that every part of the community that's food insecure gets some level of service. We were pretty good on having families pick up food when the kids were not in school, for example. Let me give you an example from Hunter College years ago. I discovered the kids at Hunter, which is in the middle of New York, but with lots of poor students that worked, working class kids. Their major meal was at Hunter, we discovered. So we had a blue plate special for $1.25. The workers at Hunter asked whether if they brought containers, they could take that home because it was cheaper than stopping for fast food. So we provided an opportunity for our workers at a real discount to take food home at the end of the workday that was much healthier than what they could pick up from fast food. So, every part of the community has to come together and figure out which population they can serve and then do that effectively. There's going to be a White House conference on nutrition. Hunger in America is something that we clearly can deal with by managing our way through as communities.
You bring up an interesting point, and that is hospitals and health systems cannot solve this problem by themselves. It does require partnerships. And during the pandemic, we really saw partnerships even become stronger in terms of dealing with the federal and state and local levels of involving private agencies. From your perspective, when you look at what happened during the pandemic and you look at what's happening now, how can we translate these lessons learned about partnerships into even stronger actionable strategies as we move forward?
It takes community leadership. I'm a big believer. When we did the immunization campaign to get all the kids, it was bottoms up. We didn't try a top-down strategy. It was all bottoms up. Every community had to come together with its stakeholders and figure out where the gaps were and figure out who was going to close the gaps. One of the things that I said to someone the other day is, we asked hospitals to do something they had never done before, to give people shots. Hospitals don't run big vaccination campaigns. For their workers, yes, and maybe for some of their patients that are walking in for flu shots and things. But we asked them to do things that we would ordinarily have the public health system do. But we didn't have a public health system that was well organized enough and had enough resources to do that. So we haven't started to talk about public health. I don't believe we should fund public health alone. I think that we have to think about, it's like two trains running next to each other, the medical system and the public health system. That has to be integrated. That has to be seamless, because otherwise, wherever the resources are, the responsibility is going to shift. And that's what happened during COVID, in my judgment.
You bring up an interesting point. We had an incredible partnership with our Department of Health here in the city, and University of Maryland and Hopkins partnered to really do a lot of outreach to vaccinate vulnerable populations, to really go out and educate different parts of our city. And it took that partnership to do that. As you think about that, though, you bring up a very important point: is what should be done to revitalize our federal, state, and local public health agencies?
I just don't think it can be done independent of the health systems. The resources are in the health systems, not in the public health system. I remember begging the Congress for more money for the block grant for public health. Their eyes glazed over until I started talking about emergencies and bio defense and things like that. And at that time, we were talking about the possibility of a flu epidemic. And maybe we could get some resources. I think we have to rethink the whole thing, Kevin. I would rethink the whole thing in terms of, because you can't use the health system just as the backstop. It has to be better integrated in general, not as a separate entity, but in general.
I want to shift gears just a little bit and just look at the impact of our collective history, and especially the attention that's been given to the war in Ukraine. And we were talking about food security, and we've seen members of Congress on both sides of the aisle come together to deliver aid to Ukraine. In your opinion, do you think this is a seed for future bipartisan collaboration, or is this a one-time event?
No, I don't think it's one time. I think that we can find things that we can work together on. I did when I was in Congress. We've always worked together on issues like tobacco, on public health things. We've always had bipartisan support for NIH, for example. We can identify issues. We need the self-confidence of bipartisanship, and we need leaders on both sides that are willing to talk about bipartisanship. One of the things that shocked me during the 2 years I was in Congress is even in my own party, no one ever treated me at a hearing the way people in my own party treated cabinet officers. I mean, I didn't like them much either because I didn't necessarily think they were all competent, but there was a certain degree of respect for people in the public service that we lost somewhere. And I actually said something to some of my colleagues that, and I don't mind going after a cabinet officer with a scalpel and sharp questions, but I think that the respect, whether or not we think they're a strong leader or not, one should expect. And that kind of civility looks like it's disappeared in public. In private, we got along fine. I worked on the surprise billing issue, which you know very well, with the Docs Caucus, which is mostly Republican stocks. They were very disappointed when I lost my seat because those guys really liked me, and we got along great. And we were starting to work on other issues that we could work on together.
You know, Dr. Shalala, another disappointing and I think frightening part of what's happened in our society is the national debate on gun violence and what's happened in recent tragic shootings in Texas and New York. And I know last week that Congress passed the most significant gun legislation in 30 years. And in the same week, the Supreme Court seemed to work at cross purposes, striking down New York's ban on concealed carry. Are you surprised that Congress successfully passed compromise legislation? And do you view it as a net gain or loss for the country, given the decision that was made by SCOTUS?
Well, I'm unhappy with SCOTUS's decision there, and obviously on Roe versus Wade, but Congress can overcome that by passing legislation, and New York will find a way around. I mean, they just may have to write the law differently, but yes, I'm pleased that Congress took a first step, and it took the another killing of children to do that. But I think that that step gives them some confidence that maybe they can do the next step.
You know, it's interesting. You and I, growing up in Ohio, I remember in school when we would have tornado drills. But I am thoughtful today of children having to do exercises about gun drills of someone being an active shooter in the building. And that's got to create a level of anxiety that in our children that will lead to mental health issues and a variety of other anxiety producing issues for our children. And I don't think we completely understand not just the deaths of the ones we have seen killed, but also the long-term impacts on the children who are experiencing that today.
You know, the majority of the price tag on this recent bill was mental health for kids, and for those presumed alleged possible shooters. If you look at Parkland, that young man fell between the cracks. It wasn't that people didn't go to services for him. He got some services, but it wasn't seamless. If he lived in Scandinavia, it would have been seamless. They would have started seeing a troubled child in elementary school and stayed with him right through.
You know, you mentioned Roe versus Wade and the decision that came last Friday, ending a 50-year constitutional right to an abortion. As you think about this, and I also worry, especially as I think about this, the implications for healthcare disparities and what the implications of that will be, because not everyone will have the ability to afford to travel to states where abortion might be legal. And you and I both have read all the studies that really point out what happens to women who don't have access to appropriate care. What do you think has to happen to healthcare policy to really address this as we move forward?
Well, we have to put more emphasis. This is about privacy as well as about rights, about women's rights. We have to put more emphasis. If we want to close the disparities, we have to put more emphasis on contraceptives. and make them free, affordable, whatever, because in low income communities, many people can't afford contraceptives. So we have to put more emphasis on that. We're going to have to put more emphasis on medically induced abortions, telemedicine. People are looking now at the possibilities of using telemedicine and medically and medical abortions as a possibility. But it depends on the state laws and how restrictive they're going to be. I don't know how a state can make a law that stops you from being transported to another place or getting medical advice from another state, but we'll see what imaginative things people come up with. But at the end of the day, we've already reduced the number of teenage births with the morning after pill, with condoms. We scared kids to death during the AIDS crisis, and with education. Now we just have to focus on low income communities and protect low income women and their families, and make contraceptives available, make education available. I mean, we just have a lot of work to do. Most people cannot travel. Look, I lived in the era of before Roe. It was devastating on college campuses. And I can tell you story after story about friends. I know people that died from illegal, harmful abortions because they didn't have access to a safe place. So we're going to have to figure this out until the Congress can pass a law. SCOTUS is not the last word if Congress can pass a law.
That's very true.
Overturning states.
You know, we haven't talked about this question, but you really went down this path. So I'm just going to ask you for a minute. You know, as you looked at Roe versus Wade decision, there were also other questions about other decisions around human rights that came up in some of the writings. And where do you think that will go, and where will that lead us?
I don't think it's going to go anywhere. Well, look, do I think some states are going to try to ban contraceptives? Let them try. 75% of the Catholics in this country use contraceptives. This is not going to be a popular issue any more than the Roe decision was in general, and the idea of banning abortions in cases of rape and incest. This is about a 16-year-old that's been raped, either by a member of the family or by someone else that's told to carry the child to term. And so I believe that we have a chance, depending on the congressional elections, of reversing this by federal law. This is the most dangerous. I don't know how someone could argue that the government ought not to tell you to wear a mask, and at the same time let the government tell women that they have lesser rights, that they can't control their own body.
Very well spoken. You know, you've done a lot over the course of your career, and we've acknowledged that. As we begin to bring things to closure, is there any job that you wish you'd taken or think of as the path not taken?
You know, it's always been journalism. You know, deep down in my heart, I wanted to be a journalist, and I never got an opportunity to do that. Actually, I did get an opportunity. I remember that I did get an opportunity to interview for the editorial board of the Washington Post. And I did talk to the editor of the New York Times once about the possibility of joining their editorial board, but the timing was wrong. Now, you know, I've had wonderful opportunities. I've had opportunities. Would I have done things differently? You know, I wasn't particularly in control. I had an opportunity and I just took it. And I've had a wonderful career and continue to have an opportunity to teach and to mentor young people, and to tell them just relax and not chart out their future, because you shouldn't do that. You should be wide awake when an opportunity walks in. Very
sage advice. You know, when you think about your legacy, and there's a lot to think about there, what do you hope people will remember most about you?
that I was a patriot that loved my country and served it well.
And you made a huge impact in this country.
Well, thank you.
Under several presidents. And so you were to be congratulated because you were very successful in working both sides of the aisle, clearly. You know, you and I were talking about our fondness of Tony Fauci, but I have also learned that your dog is named Fauci.
He is.
And, first of all, I want to know, does Tony know this?
He does.
And
He
have
does.
the two Faucis met?
They have not. Tony, I did send Tony a picture and he said he was cute. And I did name, I have a COVID dog, a little dog that I should show you a picture. Can you hold on for 1 minute?
Yep.
You know, I hadn't had a dog in a number of years, and someone called me from a rescue group that I worked with, and they said there was this little dog. I had never had a little dog before, running around in Coconut Grove, and they had just caught him, and he had all sorts of problems, and he looked like he was about 4 years old. And I went to see him, and he was adorable, but really sick. And they said, well, you have to give him a name right away. And they said he ran into an Italian restaurant. So I thought immediately about Fauci. Let's see. Can you see this?
It looks like the dog has found the right home now.
Yes, he's a mutt. He's a pure mutt.
Well, I think our fondness for Tony.
A strong personality.
You know, I want to thank you, Dr. Shalala. This conversation has been a pleasure, and it's been an incredible opportunity for me to personally spend time with you. But we are out of time. And as we close, I want to acknowledge the importance of effective leadership in managing the many challenges our world is facing today. Forums such as this provides opportunities to learn from leaders who have ably navigated political hurdles to effect a positive difference. On behalf of the people of Johns Hopkins University and Johns Hopkins Medicine, we thank you, Dr. Shalala, for sharing your life's lessons, your wisdom, and your time with us today. And finally, thank you to our audience for joining us and for sending in your questions. We hope to see you all at the next Johns Hopkins Health Policy Forum. Thank you for being with us today.
Thank you.